Hi there. I'm Dr. Richard Finn, professor of medicine in the Division of Medical Oncology at the Geffen School of Medicine at UCLA and the Johnson Comprehensive Cancer Center here in Los Angeles. And thank you for joining us for this section on GI oncology now. I'm joined by Dr. Adam Yopp from UT Southwestern. And today we'll be talking about the IMbrave050 study and, in general, the landscape for adjuvant treatment for earlier stage hepatocellular carcinoma. Adam, thanks for joining me today.
Thanks for having me, Rich.
Do you want to give an introduction for your position
Yeah,
for the
so I'm
audience?
I'm a professor of surgery at UT Southwestern and the chief of the Division of Surgical Oncology here in Dallas.
And part of the steering committee for the IMbrave050 study. And IMbrave050 evaluated atezolizumab and bevacizumab, a regimen that's approved for advanced liver cancer in early stage liver cancer. And just as way of background, we know that the only way to cure liver cancer is with surgery, either resection or transplant. Here in the US, in the West, many of our patients have underlying liver disease and portal hypertension, so they are not necessarily going to go to surgery. More often, if we're going to try to cure them, they'll go to transplant. But still, there's a subset of patients who are well compensated and we know when they have surgery, there's a high risk of recurrence. And unlike breast cancer, colon cancer, where adjuvant treatment is very well defined to improve outcomes, in liver cancer, that's still an unmet need. And IMbrave050 really was looking to fill that need. Now, with that background, can you go into a little more of the details of the study design?
Yeah, and I think you hit the nail on the head. We know that the risk of recurrence is extremely high after curative therapy. And so with in the advanced setting, with the atezolizumab and bevacizumab having a positive signal in IMbrave150, the natural kind of the next study was to design an adjuvant study. And this is a worldwide study where the patient population was the first diagnosis of hepatocellular carcinoma who had actually undergone a curative resection or ablation and remained disease-free or margin-negative resection following surgery. The patients were We tried to pick patients who were at high risk but actually had preserved liver function, the same patients that we're seeing that we're operating on. So they had a Child-Pugh class A liver function with no evidence of extrahepatic disease and a good performance status. What we were interested in is determining this group of high risk of recurrence, and I think that was probably the hardest thing when we designed the trial is what is high risk of recurrence, and that's where I think it became a little bit difficult. We included tumor size, which we felt was for high risk of recurrence, as well as macrovascular invasion with VP1 and VP2 included within the trial itself, or poor tumor differentiation. So large tumors greater than 5 centimeters or greater, multifocality, or macrovascular invasion. The thing that we did not include was alpha fetoprotein, and that drew a lot of criticism during the trial when the readout. And I think more of that criticism was from the Western world, which uses alpha fetoprotein, I think, a little more routinely as determining high risk of recurrence. We felt in the steering committee that alpha fetoprotein was simply a surrogate for what we actually chose as high risk of recurrence. And so we didn't specifically have that as a kind of a marker of high risk of recurrence or include that in the trial.